the theme this morning is where are we coming from? And from an aesthetic perspective, I would like to give you a very close look at the system that we are using to plan our implant restorations. So it is an aesthetic occlusal system. It is step by step, and we are using it so that the interdisciplinary team has a common ground. So let's get started right away, and I'm going to give you 7 steps. So step number 1, what you need to do is always set the incisal edge first, and you're going to set it against the upper lip at rest. And let me tell you, this is very convenient because we have in the literature very firmly established data from Vig and Brundo and from Dickinson Sarver, and they give us a lot of numbers. And from there, you can make your own system. So what I would like to submit to you is the following sequence. If you're dealing with a male patient, you probably will shoot for a rather discrete display, let's say up to 2 millimeters beyond the upper lip at rest. Now, if you're dealing with a lady who wants a smile which is relatively conservative, not too strong, then you're going to be dealing with about up to 3 millimeters of display. And finally, let's say you're dealing with a more sparkling smile, and the patient wants to be more like a magazine style, then you may have to go up to 4.5 millimeters. So we're going to take a male patient. He had to have a total reconstruction. And you can see from the beginning, again, against the upper lip, you have no display. And we talked about the requirements for maxillary incisal display. Now, let's look at guidelines against the lower lip. What we try to set is no more than 3 millimeters against the lower lip, because realize your opening vertical dimension, and if you go beyond 3 millimeters, sometimes there is too much focus on the lower incisors. So we go maybe up to 4 millimeters, but that's the absolute maximum. Then we go to step number 2, and that is set the incisal profile. And you want those restorations to be within the lower lip, and that is, you want to have them with the wet, dry part of the lower lip. So you all remember the test that we all learned in dental school. You ask the patient to say 45, 45, the FNV test. So let's now look at this patient, and let's try to apply this sequence, because there are a lot of other problems that are drawing our attention. This is a young patient. He needs 4 implants. He had 4 implants. He had a car accident. You can see a very irregular occlusal plane. You see that the lower incisors have super erupted. And not only have they super erupted, they also are very flared out. And we are going to follow step number 1, set incisal length. Step number 2, set incisal profile. So let me remind you this. It's very simple. The upper lip sets step number 1. The lower lip controls step number 2. I repeat, the upper lip sets step number 1. The lower lip controls step number 2. So what you have here is a denture setup or a bisacral setup. From here, you realize that the posterior teeth cannot come into occlusion unless you intrude the lower incisors, you round the lower arch, you level and align, you extract one lower incisor, and now it's becoming interdisciplinary. And you have to level the occlusal plane as perfectly as you can. And Maguire and Jensen showed that the use of TADs is very instrumental to finish a case like that. And you know, when it boils down to restoring the patient, and you're looking at this mini PIB, every decade we have been reminded by many authors. I mean, look at those names. Those are the pioneers of aesthetic dentistry. We have been reminded that every decade how critical the control of incisal edge is, both vertically and horizontally. Now, it's for obvious reasons. But I'll give you one important reason to me is that you're controlling light reflection, because the light that hits the cervical goes back up, the light that hits the incisal goes back down, and the light that hits the facial aspect, you see, look at the highlights right in the middle, it goes back straight to you. The control of light reflection is what you get by controlling incisal edge, vertically and horizontally. Now, we're going to look at number 3 now. You need to determine your proportions. And at some point in this reconstruction, we are going to plan from the incisal edge up. First of all, let's look at the case a little bit closely. This is a total reconstruction. In the anterior zone, you have Procera zirconia. And the combination we use, we've been using that for 10 years, is by layering with a Noritake CZR. This combination was very well documented by Marcus Blatz, Stephen Chu, Gordon Christensen, and they showed that the performance is just about identical to PFM. So we're using this with great confidence. So you have the preparations, we're going back in the treatment, and at some point we look at incisal edge position, remember the sequence, but when you now look at the pre-op, and it comes to establish the central incisor length. So we looked at upper lip, we look at lower lip. Now step number 3 is time to look at the face. And the system I would like to show you is very simple. The face will generate the general length of your central incisor. Tell yourself short face, 10 millimeters. Average face, 10.5 millimeters. Longer face, 11 and up. So the minimum is 10, but you can be flexible above 11. So the idea is the incisal edge sets the gingival level. And from there, the width can be set at about 75 to 80% of the length. And now you have designed your central incisor. So for this case where we need veneers and implants, you can predict that if your length is 10 millimeters, your width will be 7.5 to 8. It's a range, of course. Those are just guidelines. And you can predict that if your length is 11 millimeters, your width will be 8.5 to 9 millimeters. From there, you're going to look at the rules of Steve Chu, which are very convenient. Because Steve gave us the rule of the 2 millimeters. And what he says is, on average, a lateral incisor is narrower than a central by an average of 2 millimeters. A canine is narrower by about 1 millimeter compared to a central. So the idea is the central incisor helps you to generate the laterals and canines. Again, those are guidelines. From here, you can use your art. So now it's time for step number 4, and we are looking at our gingival levels. So this patient, of course, you all seeing this, needs to have better symmetry around the central incisors. And in addition, let's look at the canines. Because, of course, with the canines, you have an aesthetic liability, of course. But it is the time to look at function, because what does it mean when you have canines that sit so high? It means you have no canine guidance. So here is a patient referred to you by the orthodontist. They are asking you to help set them up for the final tooth placement, and you realize that you have deeper problems than that. You have no canine guidance on one side, and you have group function on the other side for a young patient. And we don't want that. So part of the prescription will be to ask the orthodontist to erupt those canines down, so that by the time you get to your wax up, by the time you get to your mock-up, you now have everything set up functionally. So the way you combine occlusal aspects with aesthetic aspects is to tell yourself, when you set proportions, it is time to really focus on the canine guidance. And it is easier said than done, because you need to take your focus out of the implant zone. And now you need to look at intact teeth and make sure you have the right prescription. Because at this young age already, you want the canines to protect for years and years those lateral incisors. You want to protect your porcelain. And I will tell you this because we got caught many times by surprise with this. There are many scenarios where the canines are not doing their job. I'll show you another example. And you know, we're concentrating on incisor implants. So we take this lady, she has a very bad surprise. This is at the end of orthodontics. She comes to see us and we bring her the sad news. We are losing 2 incisors. But get your focus out of the aesthetic, of the implant zone. Now, look at the canines. You look at number 11 or 23 for the international system. You notice it's slightly rotated. And in addition, it's a little bit high up. So we could speculate that maybe that canine had been impacted before and it had been dragged down through into position in the arch, and maybe it resorbed the roots by traveling across. So this patient, of course, you know, doesn't want to hear. We want to bring the canines down orthodontically, and we're going to recommend a veneer. Now, there is another situation that happened here, is you have extremes in abutment colors. So when you have extremes in abutment colors, when you have a checkerboard effect, be very careful if you use a ceramic material that is too translucent, because you're going to have uneven reaction to light. So what we like to do is to equalize the reaction to light with zirconia material. And that's why you have seen such a resurgence of zirconia applications in the last 3-4 years, because what the zirconia will do is equalize the reaction to light, and then your ceramist will layer the aesthetic porcelain on top of it. It's exactly the same system. So let's stay with gingival levels, and let's look at interpapillary heights and prediction. That was another case. So you have many authors, starting with our good friend Bill Becker, who have tried to give us guidelines on gingival height. And the final numbers probably have been given to us by Garber, Gastaldo, and Tarnow. And it's very well known now that the interdental papilla height between implant and natural teeth is about 4.5 millimeters on average. And between adjacent implant is about 3.5 millimeters. So Denis Tarnow made a very astute observation. He says, you know, we as dentists, we notice short papilla, okay, but what do patients notice? What is their first impression? And their first impression is a sense of balance. What they want to see at first is symmetry. So our patients are more sensitive to symmetry, provide pleasing balance, than short papilla. So use that to your advantage. And as a consequence to it, you need to avoid having a pair of implants on one side of the midline. So it's easy to say, make sure that you will have, let's say, on a case like this patient, always one central incisor implant and a lateral incisor cantilever. This patient doesn't want it. This patient wants you to place 2 implants to restore those hopeless central and lateral incisor. They have vertical bone loss in nature. The rest is horizontal bone loss. Those teeth will be saved, but this patient does not want to floss under a cantilever. And maybe you had patients like that. So we have some very good guidelines established in the literature with orthodontic eruption. And you know, I always remember a very important rule given to us by Vince Kokic. He will always tell you, when you force erupt, make sure that you force erupt vertically. And that's why you see the adjustment of those central incisors very aggressively, because you don't want to force erupt at an angle and you will lose facial bone. And the results can be dramatic. and look especially at the bone defect resolution between the central incisors. Not only that, look at the development of the interdental bone peak between central and lateral. So from there, the Loma Linda group, led by Joseph Kahn, gave us a system which is the sequential extraction system. And what they recommended is you are going to extract and place an immediate implant for one central incisor. So we place the replace select here. Wait about 6 months, so your temporary is supporting the interdental papilla, and then extract the other incisor and place the next immediate temporary. And with that system, they reported reasonably good maintenance of the interdental papilla height. Now, this is a treatment that will take time. So it is not for every patient because it's a lot of interdisciplinary treatments. You have to have good patient selection. You have to have good patient mindset for this type of sequence. Now, this patient here, you have a lot of work because this patient is post-orthodontics. And probably she had some extreme relapse. It's very hard to know what happened. You notice there is a very strong aesthetic cant of the premaxilla. And when you see this resorption of the incisors, certainly, you're thinking, so what are my options? And perhaps we can think of pink porcelain. There are many ways we can help this patient. You need to look at this patient comprehensively. For example, just to look at the lower arch, there is some mild mandibular tooth size excess. So what does it mean? It means that you have an excess of about 3 millimeters. And you could think of stripping and realigning, but somebody like Zilich said it's much more simple to extract a lower incisor in a case like that. All right, so we'll extract a lower incisor. But be careful, when you extract a lower incisor, what happens to your canines? Your canines move to the mesial, so now your canine guidance changes. And what happens? You're going to pick up bicuspids in your guidance. So be prepared maybe for some partial group function. See, you have to look at the total picture. And so we start the interdisciplinary treatments. We extracted the lower incisor. We are force erupting the 4 incisors very slowly. We're gonna give it a chance. And now it's time to really team up to make sure you're going to end up with a moderate guidance. So let me tell you what I mean by that. At the end of the treatment, when it's all said and done, I do not want to end up with a very tight relation. That's number one. I don't want to end up with a very deep relation. That's number two. I don't want to end up with a relation that's too flared. That's number three. And that can happen if you focus too much on the implant zone and you don't pay attention in advance to your relation. And the fourth thing is I don't want to end up with very thin porcelain because everything is pushed out. So what I have in mind is the design in red. What I want is a moderate guidance whenever I can get it. Now, there are variations around it, but the reason I want to take advantage of it is that Larry Weinberg showed very conclusively that for every 10 degrees in the guidance that you can change, so we talk about the interincisal angle here, for every 10 degrees, you're changing the force 35%. Think about it, it's enormous. So I want to take advantage of this opportunity, and we will make sure that we do not end up with relations that are too tight at the end. Now, there is another interesting study that came out from Italy, from the group of Amato, where they documented a pretty large group of hopeless teeth that they erupted for the purpose of implant site development. And what they reported is that the gingival movement will be about 65% of the tooth movement. Okay, so you erupt the tooth 1 millimeter, the gingiva follows 65% of that. And the good news is that the bone follows 70% of that. So this lasted about 1.5 years. And to the point that we're going to have flapless surgery, very simple extraction, and just with guided surgery. No augmentation of any kind was done. And when you look at those pictures right before extraction, this is an exact illustration of what Henry and Maurice Salama told us 20 years ago. And that is, you can utilize hopeless teeth for the implant site development through orthodontic eruption. So we gave it a chance. The patient knew maybe it might not be predictable, but we tried. And so very simple guided surgery. And now, selection of implant placements. We selected 2 narrow diameter replace implants in the lateral incisors. So one reason, of course, is the bone availability. How is your site availability? But another reason is that you have a very good study by Krenmeyer, who documented 25 fixed partial dentures of that design with 2 lateral incisors in the maxilla, 2 lateral incisor implants. And he looked at those 25 restorations for 56 months average, plus or minus 10 months. What was the success rate? 100%. 100%. Now, of course, we know that there are many other authors who are thinking otherwise. They would prefer to place them in the central or alternate or even place 4 implants. Whenever I speak to a study club, I always like to ask every time the periodontists, the oral surgeons, if you have bone availability, what do you prefer in general? And with all the discussions we have, at the end, it boils down to those two options. You have the classic recommendation of Francesca Balati and Urs Belzer. So you have the Swiss group that will recommend 2 lateral incisor implants, narrow diameter, and narrow diameter so that you don't impinge on the embrasures. And you have the Spanish group of Velanibo, who gives you as many good reasons why you should go with 2 central incisors. Again, as long as you have bone availability. But remember this, though. The 2 central incisor regular diameter implants will give you a wonderful opportunity if you use platform switching to your advantage, because that way it'll maintain as best as possible the interdental bone peak. So let me digress for a second, because I want to show you this case here done by a very good technician, a friend of mine. You are looking at 2 lateral incisor implant situation, and you're looking at 4 unit. You're looking at the wax up on the left, and the restoration was an Emax lithium disilicate 4-unit fixed partial denture. Look what's happening. It's fractured very quickly in function between the central incisors. Why? Emax, of course, is an excellent material, but the problem with any ceramic material is when you take it to the limit. And from there, anything can happen. What happened here is that, and I'm speculating, the ceramist is trying to give you better aesthetics. So they carve deeper into the embrasure between the centrals. And what do you get? Well, you get a connector size that gets smaller. And all this is telling you here is whatever that connector size is was not enough for the patient. So add to that checklist, how much connector size are you going to generate if you use that that system. So watch out with your lower incisor. Remember the guidance? And finally, what framework material will you select? So this is why our ceramist, Aram Tarosian here, decided to use zirconia. And the connector size I'm giving you are very well established with one ponic. So if I have one ponic in the anterior region, I need 7 square millimeters of zirconia, certainly more for lithium disilicate. But realize that those data are for one ponic. So for 2 ponics, how much do I need? It's unclear. I don't have any data. But you can tell we're trying to get what? Minimum 9 square millimeters. So how do you do it? You do it by bringing the zirconia connector all the way out to the lingual. And this is a design I learned in the 70s from John McLean. John McLean was my big mentor. The late John McLean was my big mentor in ceramics. And what he taught us at that time was the stress are always in the connectors and maximize the strength by bringing struts to the lingual. You get another advantage with that technique. You can bring the embrasures of your framework lingually so that you can develop better aesthetics on the facial. So you have better control. So we're going back to the mouth. The ponic sites were developed in the provisionals, are recorded with acrylic resin, then connected to the implant posts, and we are extending our restorations to first molars so we can have more aesthetic control for that patient. When you have a zirconia framework, you often notice that some technicians like to bring the framework all the way to the incisal edge on the lingual to give you more strength. And I would caution you to be very careful with that because you do not want to block light. So make sure that you provide incisal translucency and keep it free for light transmission. So we're going to try to marry here a little bit of sparkling with a little bit of natural for the patient. So the central incisors have a little bit brighter value, lateral just a hair lower value, canines lower value. We learned that from Willie Geller in the 70s. And vertically speaking, there was no augmentation. There was no bone augmentation. There was no connective tissue grafting. And it was flapless surgery. Patient is missing bicuspids. In the maxilla, you only have one bicuspid either side. The conclusion of our system. It's very fine to talk about aesthetic, but make sure that you interject your function. And this is the blueprint we use in the center for the team. And with this is our system, and this is it. Thank you very much for your attention. Thank you.